All right, now I have the pleasure of introducing myself, which is good for two reasons. So first, I didn't send through a bio through, so who's better to introduce themselves than themselves? But secondly, because I didn't send one through, Jeffrey had an open slate to say anything about me, but he didn't turn up. So the joke's on him. All right, so I'm an ID physician at the PA Hospital. I'm also at Greenslopes Private Hospital with Evan Bursell, and Peter Simos is sitting in the room as well. He does a bit of work with us. I am trained as a clinical microbiologist as well. And Adam's given me the pleasure of talking about bloodstream infections in kidney transplant recipients. So I don't really have anything to disclose. And look, we could get all caught up in sort of where has this bloodstream infection come from? And bloodstream infections are common sources of sepsis. And really, we don't really care about most of these ones. In kidney transplant recipients, the one thing that differentiate them from non-transplant patients is that they've got a transplant. So here's a case from a few years ago. A 56-year-old male who had a deceased donor kidney transplant 1 year prior to meeting us, and this was for a diabetic nephropathy. So he was on fairly standard immunosuppressive therapy at this point in time. He had very minimal post-operative urologic interventions, just removal of stent, and presented to hospital with fevers and pain. So he had a blood culture and a urine sample taken on admission, which cultured a Klebsiella pneumoniae, which had an AMP-C phenotype. It wasn't all that special in terms of its susceptibility profile, but like a lot of our AMP-C producing pathogens, it was resistant to oral step-down options for his treatment. So he was treated initially with piperacillin tazobactam, and then changed to meropenem when this susceptibility result came back. He had a gallium scan fairly early on, which I'll sort of go through the utility of gallium scans later on, but he ended up getting one quite early because of the concern about transplant pyelonephritis, and that did show focal uptake in a region within the transplant kidney. And he was treated for 42 days with home antimicrobial therapy in the absence of any step-down therapy. And that was based a little bit on his progress, on his inflammatory markers, and on his general sort of, treatment sort of progress while we sort of caught up with him weekly in clinic. So he completed his course of therapy, and then he represented 12 weeks later with fevers and pain over his graft site. And again, a blood culture was performed and a urine culture. He actually presented to a different hospital, then got transferred to ours. At this other hospital, he had another Klebsiella pneumoniae isolated, but actually came out as a non-AMP-C phenotype. So there was no resistance to any of the third generation cephalosporins, and it was cafoxidin susceptible as well. So again, limited options in terms of his treatment for oral step-down therapy. But when he came to our hospital, because he was still spiking fevers, he had another blood culture on admission, and this culture actually isolated the original strain as well, which was an AMP-C phenotype, and again, had that same resistance profile. So he was recommenced on meropenem. He was treated for another 42 days and went home during that time, and had a gallium scan sort of about at the 6-week mark. So that's why I mentioned 42 days. And again, it showed that focal uptake in the transplant kidney, which was pretty much in the same region as the earlier scan was seen, which was now about sort of 16 weeks prior. So we actually then decided to keep him going for 6 months. Now that seems like a really long course, and in hindsight it was. But after 181 days, we did another gallium scan, and it had significantly improved in that region. It hadn't completely resolved, but we were at the point where we thought, well, 6 months, what are we going to do now? We might as well stop. Which we did, and then he relapsed 1 month later. So he had his transplant out, which is probably not a great outcome for him. But we kind of feel like we threw everything that we could at him to get him to this point. And I think, as Samuel mentioned, by this stage, as a consumer, he was just over the whole process of being on almost continuous IV therapy. So it was probably an inevitable outcome for him. Another patient just around the same time presented with transplant pyelonephritis. He had a first episode in blood culture and urine with a non-ESBL AMP-C phenotype E. coli, which was treated with piperacillin tazobactam for 15 days, a short course for us, you might say. He had a recurrence in urine only and was treated with a combination of 11 days. So, when it recurs, goes shorter. Had a second recurrence. This time we changed things up and went for a bit longer, so up to closer to the 10-week mark. I had a third recurrence, which was in blood culture only. So we tried a different antibiotic. It had 14 days and he cured. So what do we make of this? It's just all made up. Patient number 3, he had a episode of, again, a non-ESBL AMP-C phenotype E. coli transplant pyelonephritis. So he had a first episode in blood culture and was treated with 65 days of piperacillin tazobactam and augmentin duophor as a step-down option. First recurrence was treated with ceftriaxone instead of piperacillin tazobactam, just to do something different. The second recurrence was then treated with ceftriaxone and ciprofloxacin, followed by Augmentin to take him up to over 6 months of therapy, and he cured. So just to show that sometimes you can not use sort of long-term oral IV therapy. Sometimes you can give them long-term oral therapy. So this is the worst of the worst. This is work that Platon Toptiani did as part of his infectious diseases training, just reviewing sort of some of the cases of transplant pulmononephritis that we had seen recurrently through our clinics over about a 5-year period. So these were 12 patients with 28 episodes in total. They were predominantly MDR phenotypes, so I showed the patients that had non-ESBL, non-AMP-C phenotypes. But even amongst those patients, we had very limited oral options in most cases. We used multiple forms of imaging on these patients. So typically during the acute episode, they had an ultrasound or a CT scan, depending on the sort of decisions at the time. Most of these patients got gallium scans, not always first up, but at some stage through there. And most of the times they had multiple gallium scans. And there was a lot of clinical uncertainty. So how long do we treat for? The numbers were all made up and they didn't seem to correlate with efficacy in some of these situations. What was the best use of imaging, particularly the role of gallium scan in these patients? And then what to do if there isn't an oral step down for our patients. So we will confess our skins. We floated with fosfomycin for a number of these patients. It didn't work. We then went over to pivmecillinam, which worked even worse, I have to say, and then farapenem, which performed the worst, which is not surprising because it did fail a clinical trial for cystitis in Japan. And farapenem was probably the one where we saw patients with persistent symptoms, and when we stopped farapenem, they relapsed within days of ceasing therapy. So we felt like we had to trial some sort of oral step-down therapy, but we realized over time that when the oral step-down therapy was likely to be inferior, that we would just have to continue on with a prolonged IV course. So just to step back in time, I know not everyone in the room is an infectious disease physician or a clinical microbiologist, and that's great because it brings together a lot of resources and a lot of different thoughts on how we best manage these patients. But I'm really focusing on acute pyelonephritis and complicated urinary tract infection, rather than sort of dealing with the acute simple cystitis that involves the lower urinary tract without evidence of a more systemic involvement, and certainly without sort of indwelling devices, be that a ureteric stent, a nephrostomy tube, or a long-term indwelling catheter, which a lot of these patients, particularly early on, typically have. So with bacterial infections, there's also a few definitions in the literature which are important to remember. Relapse being an infection that occurs with the same uropathogen within 2 weeks of ceasing your previous therapy, whereas reinfection or recurrence being an infection that occurs more than 2 weeks after the end of treatment, which may still be due to the same pathogen, uropathogen. However, it can also be a different uropathogen as well. Recurrent urinary tract infections, which gets branded around quite a bit outside of transplant cases as well, but is really defined by the occurrence of 3 or more urinary tract infections in a 12-month period, or 2 more within the last 6 months. And that can also include patients who have recurrent cystitis as well, though we're possibly more interested in the urinary tract patients, or the more complicated patients in this transplant group. So the growth of a uropathogen without symptoms does not equal relapse or infection. And I think that's a really strong point here, particularly with a lot of sort of the definitions that once you treat the patient, we are not necessarily inclined to repeat a urinary sample just for the interest of it or to see if they've cleared it, because what's important for the patient is resolution of infection rather than continued growth of a uropathogen when it's asymptomatic. So there are a few risk factors for transplant pyelonephritis or complicated urinary tract infection, and these are frequently the same as for non-transplant patients, so being that female gender, older age, a pre-transplant urinary tract abnormality, diabetes, history of recurrent urinary tract infections, and polycystic kidney disease. All of these we recognize amongst the non-transplant cohort. Within the transplant group, though, there's a few important points. Now, immunosuppression is definitely a risk factor for transplant pyelonephritis. But this quite nice study in Spain, which looked at 4,000 solid organ transplant recipients, compared sort of, I guess, the kidney transplant patients against the non-kidney transplant patients, and found a higher rate of pyelonephritis amongst the kidney transplant patients and urinary tract infection, and all cases of pyelonephritis occurring amongst the kidney transplant recipients. So it's not just the immunosuppression, it's the renal tract and the abnormalities in the anatomy which contributes to it as well. And in particular, that's ureteric reflux, which is really important, as well as the ureteric stent. And it seems that the earlier that the stent is removed, the lower the incidence of urinary tract infections are. So I think in our cohort of those 12 patients that we looked at, the median time to removal was around about the 42-day mark. So that was actually a little bit sort of late compared to what's been proposed elsewhere. Prolonged use of an indwelling catheter is important as well. So it does seem to increase your risk of a urinary tract infection by about 33% if it's left in for 9 or more days. And that makes a lot of sense, particularly when we look at catheter studies where the cumulative incidence of colonization of the catheter increases by about 5% each day that it's left in situ. So as Samuel mentioned, deceased donor transplantation has higher rates of complications, and it's true for transplant pyelonephritis as well, where a living donor transplantation is associated with a lower incidence of UTIs. So just to put all these things together, we can think about the pre-transplant risk factors when we're sort of looking at our patients. Obviously, we can't do much to change that by going back in time. There are graft-related factors. Again, we don't seem to really be able to do much to change those. And then there's the post-transplant period. And it's obviously important that our surgeons are still involved in managing these patients, particularly when they have reflux as an ongoing issue or a ureteric stent. So long-term outcomes, look, this is a little bit challenging. There's a lot of studies on long-term outcomes, and it's no surprise that recurrent infections is associated with a poor outcome. But what I found interesting from this study, which was a French cohort of 9,000 kidney and combined kidney pancreas transplant patients, was the cumulative incidence was 20%. That's a lot of transplant urinary tract infections through a 10-year period in their cohort. Early transplant pyelonephritis, so infection within the first 6 months, didn't seem to significantly increase the risk of graft failure, which is an interesting finding. However, recurrent episodes, particularly where they have 3 or more episodes, and that's within a 12-month period, or late transplant pyelonephritis where they have an episode after 6 months, both of these are associated with a hazard ratio of about 2 to 2.5, and that's on a Cox multivariate logistic regression model weighted for time. So it's always tricky when you're doing these time series and looking at incidence over time. But I think this does show the impact, not just on the individual case where patients have to be managed, but also on the long-term impact for our patients. So I mentioned gallium scan, and we've had a really good think about the role of gallium scan in our patients, because first of all, has been relatively easy to get until sort of relatively recently when there was a shortage. But we did use it on a lot of our patients. So gallium seems to make a lot of sense for kidneys. So about 10% remains after 24 hours in the plasma, but most of that 10% is then excreted sort of through the GI tract. 10 to 25% of it goes through the kidneys within about the first 24, 48 hours. So after that time, whatever then goes through the kidneys would seem to be consistent with focal areas or diffuse areas of inflammation. So it does make sense that gallium scans are utilized for diagnosis of transplant issues. It's probably slightly better than PET scans from the literature that I've seen, but I don't think you can say that definitively for kidneys. And the deposit of gallium in the kidney seems to be related to a number of factors, being the end result of labeled leukocytes, but the presence of organisms, protein accumulation, vascularization, just areas where we expect to see driving inflammation. It increases with time to the infectious site. So it's probably has its maximal sort of uptake within about 5 to 15 days. So it doesn't make it a very useful test for repeating it early on. So it's probably a test that if you're going to use it, you might do it early and then might do it quite late. Doing it sort of, every month seems to be quite a pointless test to do. And I suspect the nuclear medicine physician, unless they're really driving up their numbers, will tell you to not bother. There's a number of other causes for deposit of gallium within both a transplant kidney and a native kidney. And it's important to be aware of all of things. I think you would generally expect if the patient presents with symptoms of pyelonephritis and has a bloodstream infection, and we have cultured the organism in the urine, that we would expect a renal abscess or pyelonephritis. And pyelonephritis can be diffuse or focal, but we would generally sort of look at that for that reason. It's a bit more tricky when a gallium scan is done for sort of investigation of a PUO and picks up diffuse deposits through the transplant kidney. There have been a number of cases of transplant pyelonephritis diagnosed on biopsy, and there's also a risk of introducing infection on biopsy of a transplant kidney as well. So it's not without sort of its issues. The sensitivity seems to be quite good for gallium scans. It's roughly about 80%, if not a bit higher. Specificity is probably about the same. Where we would like to see a test come forward and be helpful is to guide us in terms of our test of cures for a lot of these patients. So treatment, again, this is sort of, as I showed you before, has been quite different at our institution at least. And I can tell you that during that time when those patients were treated, Jeffrey was actually the main sort of transplant ID physician doing that work. So blame it all on him. I think he was just a bit schizophrenic when he was sort of coming up with his different sort of durations. But anyway, we use the same principles as any other bacterial infection. So we try to apply to that drug-bug combination where we think there's going to be the best outcome. As I mentioned, our oral step-down therapy now has been quite limited, but we would prefer to use a fluoroquinolone. We believe that probably has been better outcomes with the fluoroquinolone than a B-lactam for step-down therapy, but perhaps if the beta-lactams continued for a bit longer, then it might be okay. The guidelines still suggest that 14 days of total antimicrobials for initial episodes should be okay. They do say that most of that should be intravenous and the patient should be admitted to hospital, at least for the early acute transplant pylos. And I think a bacteremic transplant pyelonephritis should probably be in hospital and investigated one way or the other. The European Urologic Association doesn't really talk about the antimicrobial treatment, but they do talk a lot about surgically managing reflux, which drives a lot of the transplant pyelonephritis cases. And they talk about sort of injections, which have a success rate of about 50% the first time and 79% the second time, or reimplantation of the native ureter as a second option for their patients. So they have really sort of driven more towards a surgical management rather than a medical management. I think it's fair to say that there's not a lot of evidence around the medical management. So it's interesting that I could find one trial that I thought was helpful. I think this meeting is focusing a lot on clinical trials. And this is a French trial, which is multi-center. I don't think it's international. And it's a comparison of 7 days versus 14 days of total antibiotic therapy for patients with their first presentation of acute pyelonephritis in a kidney transplant recipient. It's a couple of things to mention. So it was meant to start at the end of last year. It's not started recruiting yet. I'm not sure what the delay is, but like all trials, there's always a bit of a estimate and then a real time when things kick off. It's going to run for about 3 or a bit more years. And the primary outcome, I think, is really interesting. So it's a investigator-led study, so they're focused on clinical cure. But for some reason, they've also included the FDA EMA definition of microbiologic eradication at the 30-day sort of review mark, which I think is interesting for an investigator-led trial. My personal feeling is that we should be focusing on clinical cure rather than sort of whether there's still the presence or absence of a uropathogen in the urine culture. Just to quickly mention, there are some new diagnostics. I can't see this coming too soon, but the one on your right is a patient who doesn't have infection, and the one on your left is a patient who has a renal transplant, and then where the areas have lit up superior to the transplant is an infected cyst in a patient with polycystic kidney disease. So this was a combination of MRI, which you can see is the T2-weighted MRI with the very good sort of red arrow, which indicates that there is an abnormality going on. And then there's a chemokine receptor, CR4 ligand, which is utilizing a targeted PET approach, which then sort of goes to the area of inflammation and seems to be quite good for kidneys compared to sort of the usual FDG PET CT scans that we typically get here. So just to summarize, so transplant pyelonephritis, it really does remain an ongoing issue. Recurrent episodes are associated with graft failure. We see lots of patients who've had multiple episodes. We seem to have had less of those recently because the episodes that we've had haven't been the MDR pathogens who have been able to, I think, utilize fluoroquinolones a bit more. How long to treat? Well, we've pulled ourselves back to 14 days based on sort of our review of what we had been doing and the inconsistencies. But you can choose your own adventure for recurrences and go as long as you want. Gallium, they're widely available. They're probably helpful in diagnosis, but they're not perfect for resolution or test of cures. And if you don't have an oral step-down option, then get an early PICC line in and beg your HIS team. And it works out well if they happen to be in another catchment, because then you can send them to there, which we have done quite frequently as well.